I would now like to invite Dr. Janet Coffman to come up to the podium. She's an associate professor at UCSF, and she's authored numerous publications on healthcare workforce. When we thought about hiring an independent evaluator for the project, we used an RFP process. We got some amazing proposals, but the proposal from Dr. Coffman and her team was the best, and a lot of that had to do with her strong reputation and background in workforce issues. She also works with the Foundation on Healthcare Reform and is a real known expert in the field of health services research. She got her master's degree in health and PhD in public policy from University of California at Berkeley. So welcome, Dr. Coffman.
Okay, well, let's see. Okay, so far, so good. All right, well, thank you very much, Sandra. It's really a pleasure to be here with everyone today, and it's just been a pleasure to work on this project with the Foundation, IMSA, Lou, Sandra, Dr. Backer. It's wonderful. My role as the independent evaluator is not the pom-pom cheerleader, although you're doing it. Mine is the, really, show me. And I want to just at this point thank our sites. I mean, we've asked a lot of you, and we're going to continue to ask a lot of you in terms of getting the data that helps us to make an evaluation and really be able to say what the case is for the projects. And I think there is indeed a lot to be said in favor of the projects. I want to introduce a couple members of my team who are here. Our fourth member, Cynthia Whitus, is on her way. But I want to introduce Matthew Niedzwiecki. Matt is an assistant professor of economics at UCSF, and Igor Gain, who is a research associate with us. And Matt and Igor have taken on the challenge of helping us estimate the cost of these projects. We're not going to present that work today, but it's an important part because I think from the state's point of view, it's important to show that we're making a difference, that a project is beneficial in terms of health outcomes, but they're also interested in looking at what is the cost of these pilot projects relative to care as it would be traditionally delivered. So with that, I'm going to first start out with a little bit of background. I'm going to go through this briefly because I think Sandra and Dr. Backer have covered this, give you a little overview of the evaluation, and then we'll dive into some findings, some things that cut across all of the concepts and some that are specific. I'm going to give you just little thumbnail sketches of what each of these concepts are because I'm going to be followed by panels of the paramedics that are actually providing these projects, and I think they're going to be able to give you a much better sense. So if you listen to me and you're not quite sure which any of these concepts are really about, just stay with us, stay tuned, and I think you'll have a better idea. And so as was mentioned, the health workforce pilot projects were approved on November 14, 2014, and reapproved in 2015 for an additional year. And Lou, our tireless project manager, and really tireless, has submitted a request for an extension through November 14, 2017 with, well, actually, Lou submitted, but with IMSA's leadership. So OSHPD is reviewing that now, and it's, I think, certainly hope that that is renewed through November 2017. And so 6 concepts that are being tested. One on post-discharge care for folks who've been discharged from a hospital with chronic illness, frequent 911 callers, which is the subject of the blog post that was distributed earlier, tuberculosis, hospice, alternate destination, behavioral health, and there's a case study on that project, and Dr. Mackey, I believe, will be giving a talk on that a little later, and then alternate destination for medical care. The evaluation is a 3-phase process. The first phase involved collection of baseline data and reporting of that data to reflect care as it was given prior to the pilot program. And in the case of these projects, care was primarily delivered in what's the traditional 911 response. What's the traditional response as opposed to some of the concepts we're testing here. In some cases, the services we're delivering, particularly the tuberculosis, is really, I would say, Dr. Backer, really outside of the traditional EMS box. So little less of a comparison there. But that was important for OSHPD, and I think important for all of us in understanding these projects. Phase 2 focused on evaluating the training, and that was put on the core curriculum by UCLA and then site-specific training by each of the sites to prepare the paramedics for the roles that they were going to play in their particular site. And then Phase 3 covers the implementation, and that's what I'm going to talk about today. And so first, some findings applicable to all concepts. And this is challenging. Again, as Dr. Backer said, it was important to EMSA to really have each of these projects be rooted in the needs of the particular communities in which they're being implemented. And so as a result of that, we have 6 concepts and we have variation across concepts. So it's not easy to put it all together. I sometimes have a little bit of the deer in the headlights trying to take it all in. Reminds me I was at the Calgary Stampede in July, and for those of you that don't know Canada, Calgary Stampede is like the California State Fair. So we're there with our grandchildren, and at one point I'm there with our 3-year-old granddaughter near a bunch of rides and noise and music, and she's just in this, oh my goodness, I can barely process all of this. And so there are days I feel like that, but we've tried to process it all and make some sense of it for everyone. So first going to show you some data on all sites on cumulative enrollment, folks who are eligible but not enrolled. It was important for us to track those folks, some demographic statistics, and payer types, and then we'll move on to some findings that are concept specific. So this is obviously very hard to read, but wanted to just show you what we're tracking. Each month we're asking the sites to tell us how many people you enrolled for the first time and what's your total enrollment. And these numbers differ for some projects because folks are maybe enrolled for multiple months. Certainly the frequent 911 caller projects enroll people for 2, 3, 4, 6 months at a time to work with them to meet their needs. The post-discharge folks, if they're enrolled late in the month, continue on to the next month. And so for quarter 2 2016, we had a new enrollment ranging from 94 in April to 80 in June, and total enrollment from 159 to 128. If we look at cumulative new patients, so this is from the start, and we had our first projects came online in June of 2015. The last projects came online October 2015. So we had staggered start dates. There were various important local reasons why everybody couldn't just start on June 1st, 2015, as we had originally thought. So but this gives you a sense of across all the concepts, we estimate that the cumulative number enrolled is 1,174. The largest chunk of those, 781, are enrolled in the post-discharge projects. That's no accident. We have 5 sites testing the post-discharge concept, whereas a number of our concepts are only being tested in 1 site. Our lowest enrollment is in tuberculosis. That's one that's being tested only in 1 site in Ventura. And it's also a condition that's not so common, whereas for example, the post-discharge projects are helping people with things like diabetes, congestive heart failure, COPD, things that are pretty common. Tuberculosis, fortunately, is not that common in the U.S., so we'd expect that to be a small enrollment relative to some of the others. This graph plots numbers of new enrollees from June 2015 to 2016. And as I mentioned, we started out with 12 in June 2015. You see the big ramp-ups that summer and that fall as new projects came online. Enrollment peaked in February at 137 enrollment of new patients, and we had 84 enrolled in June 2016. And I should say here, we're doing quarterly reports to OSHPD as that's what they require of us, but we will be putting together a report for the public that will be released early in 2017, and that will cover June 2015 through the end of September 2016. We wanted to be sure that we had at least a year's worth of data on every project before we do a public report. These are our data on folks who are eligible but not enrolled by project. And I want to call your attention to, we looked separately at people who refused to consent and folks who were not enrolled for all other reasons. So there have been across projects some folks who have refused to consent, and when we get to our presentations, folks might want to talk a little bit about what's behind that. I think it's fair to say for some projects, you've encountered clients for whom working on their medical condition is just not what they're able to prioritize. And then all other reasons, these vary in some cases, but in lots of cases, they really have to do with availability of resources. The pilot projects can only serve so many people, and as we'll hear from Dr. Mackey, sometimes your community partners can only serve so many people, and there are people who would potentially benefit who, due to resource constraints, you can't serve. I think that comes into play, especially in San Diego. In San Bernardino, because of your resource constraints, you intentionally limited the project to a certain set of zip codes in the county, but your partner hospital serves folks from all across the county, so you have a large number of people who you don't even offer the program to because given your resources, you want to focus on this one particular set of zip codes, which I think makes a lot of sense. Actually, kind of from a research design point, is absolutely nice too, because it's sort of a reason for limiting your population that doesn't have to do with any of their characteristics aside from where they happen to live. So enrolled patients, so just a little bit on demographics. Majority of patients are male, fair number of female patients, but we're majority male. Average age varies widely across the projects, and this has to do with who's being served. The tuberculosis project and the frequent 911 and alternate destination behavioral tend to serve younger people. Hospice, understandably, is serving older people. Post-discharge projects, while folks, adults of any age can have these conditions, things like COPD and CHF are just going to be much more common in the older population. Majority of patients, non-Hispanic and Caucasian, and I think this probably more than anything reflects the fact that a large part of our enrollment are older folks. And again, you see the enrollment of older folks here in the payer type data of the enrollees across this whole period from June 2015 to June 2016. 45% were enrolled in Medicare, 27% Medi-Cal, 14% uninsured, 14% private insurance. Again, this varies. The post-discharge projects, the hospice projects, for the most part, tilt very much to Medicare beneficiaries. Although, interestingly, San Bernardino, we do see a lot of Medi-Cal beneficiaries in that post-discharge project, and I think that may just reflect that you're serving a low-income population. Some of folks who have substance use disorders, particularly meth use, that make them more vulnerable to getting things like CHF at a younger age. Certainly the alternate destination behavioral health in the tuberculosis projects see a lot of younger people who are either on Medi-Cal or who are uninsured. So just to give you a flavor for who's being served. And then now let's dive in a little bit to our specific concepts. And I'm just going to keep track of time because we want to try to move ahead and get our panels of the paramedics up a little faster. So post-discharge. So the target here is folks who've been discharged from the hospital with a chronic condition. All 5 sites are working with folks who've had congestive heart failure. Some sites are also working with COPD, that's chronic obstructive pulmonary disease, some with heart attack, diabetes, sepsis as well. But really the big one is congestive heart failure. And the idea here is folks are enrolled at the time of discharge, and they either get a phone call or a home visit, or often both, with a paramedic who sits down with them, reviews their plan of care, checks with them to see if they have all the medications they need, reconciles their medications, which turns out to be very important, helps them understand how to take care of themselves. If they need to schedule a follow-up appointment with the primary care doc or specialist, helps them get that done, helps them with any other services they might need. The goal is to help folks help themselves so that they can hopefully stay out of the hospital. And so here's some information on how they're doing. So these are 30-day readmission rate trends from the 5 post-discharge projects. We're going to span August 2015 to June 2016. We gave folks a little bit of time at the beginning of the project to get things moving before we started tracking the data. So this is 30-day readmissions, and as those of you who work with hospitals know, this is something that's of great concern and interest to hospitals because of the Medicare penalties. And so the light blue line is readmissions for any reason, and the Medicare penalties are triggered by that. So what is the rate of readmission for any reason whatsoever? We also track readmission by qualifying diagnosis, because given that these pilot projects are really helping people, aimed at helping people manage the chronic illness for which they've been discharged from the hospital, it's our hypothesis that you're going to see more traction with that if you sit down, a paramedic sits down and really works with somebody on their congestive heart failure, you should be getting the most traction on readmissions for heart failure. That's maybe a better measure of how well the program works, but we still want to track the 30-day all-cause readmission given the interest in that. And what we see, it's bounced around a bit, and I don't think we should be surprised about this. We have relatively small numbers of folks, but we've ended at the end of June with rates that are, let me get this right, about 13% for all cause and about 10% for any reason. Okay, and now clearly I have done something wrong, and okay, let's. Okay, there we go. I'm self-sufficient, Lou. Crisis averted. So about 13% for any reason, a little less than 10% for qualifying diagnosis, and this is across all projects. I mean, we're also looking at the individual projects, but for our purposes today, we'll look at all projects. So is that impressive or is that not impressive? Well, you've got to benchmark it. And so here we have our 13% rate. We're working with the project still. And folks, I know, here's this, I'm going to keep asking you for data. But we really do need to get our data in line on our eligible not enrolled during the time period that we had the projects up and running. We really want to have that contemporaneous data to say, in the same places at the same time, what's the difference, if any, between the folks who got the CP intervention and those who didn't. But these benchmarks, I think, tell us that we're at least in the right ballpark. Data from OSHPD for 2013 on all-cause readmission in California, and this is, I should label this would be for congestive heart failure here, 18% statewide. National was even higher, 24%. For whatever reason, we collectively seem to be doing better. But this is 30-day all-cause readmission for congestive heart failure. So it looks like we're doing well, and we need the data to show, to be able to show, are we really, really, truly making a difference in the same places at the same time. Post-discharge medication reconciliation, all of the sites reported devoting substantial time to medication reconciliation. And so this means taking the scripts that people got when they were discharged from the hospital, taking any prescriptions they have from the primary care doctor, the cardiologist, any other specialist, lining it all up and trying to make sense out of it. And we found that many of these patients had 10 or more prescriptions. That's a lot for any of us to keep track of. And think of some of our older folks who are enrolled in these projects who also have some cognitive limitations, and this is really challenging. And there's one of the 5 sites that found one contraindication for every patient. And so what does this mean? Well, we had one site, at least one, and I think others have found this, one patient 3 times the recommended dose of Lasix. They had gotten Lasix is, diuretic, standard for congestive heart failure. Very helpful drug. But the person had a prescription from the PCP, from the cardiologist, and from the ED, and was taking all 3. So Lasix is one of those things where you can get too much of a good thing. 3 times the recommended dose is probably going to dehydrate you and wind you up back in the ED and possibly in the hospital. So that's just one example of how this is making a difference in helping people really understand what meds they have and how to take them properly. So frequent 911 callers, if you read the blog post, you'll have even more detail on that. But this is really, I would say, this is working with the people who are hard to take care of. Some of them really hard to take care of. Folks who are often homeless, often have substance use disorders, often have mental illness, and are folks who, because of these cumulative disadvantages, challenges, call 911 frequently, sometimes once a week, sometimes more than once a week. Folks who really need a lot of help. And the idea of the frequent 911 projects is to say, well, let's stop reflexively taking these folks to the ED. Let's step back and say, what is it that these people really need? What is behind this frequent use of the 911 system for things that are not bona fide emergencies, and to help folks get what they need. And so we have Alameda and San Diego doing this work. This is just a snapshot of some of the resources that they've referred people to. Some of it's falls prevention. Some of these are folks who are older folks and live alone. Domestic violence, food assistance, housing is a big issue, transportation, substance use, homeless assistance, and I think the sites will talk a little more about this, but there's been a lot of effort here to say, well, let's get folks what they really need instead of just taking them to the ED. A little hard here to compare the projects because there's some differences. San Diego has really, I would say, focused on the super mega, what do we call them, man? Mega users, I think, yeah. Folks who are calling, have more than 20 ED visits in a year, folks who really need a lot of help. Alameda, being a smaller jurisdiction, has enrolled all who are referred into the program. So you have definitely in Alameda a few of these mega users, but you've also really worked with people who's maybe not quite spiraled to that level, but who have, say, in the last month called 5-6 times. And there's I think you found benefit to really working with these folks and seeing what can we do to get them what they really need. So just one snapshot from San Diego, there was one person whose calls were reduced from 40 per month, that's more than once a day, to 5 per month. Now, for the average person, 5 911 calls in the month is a lot. But for somebody who started at 40, getting them down to 5 is big progress. And I think Anna and her team will tell us just what's involved in doing that. Okay, DOT, or directly observed therapy for tuberculosis. This is one of the 2 projects Ventura is doing. And the idea here is really to augment the public health resources. Ventura, like most counties, has a TB clinic that provides treatment for folks with TB, but they're overloaded. And they also, I think, have found as the project's rolled on that there are competencies that the community paramedics have that are helping them to be more effective. So as I mentioned before, 25 patients to date, and the community paramedics, and the way this is staffed at Ventura is you're using paramedic supervisors. You've got folks on about 24/7. You've got somebody available pretty much any time of the day to deliver the therapy. And why do we care about it being directly observed? Well, TB being so contagious, we really want to be sure that people are getting their medication. And while some folks with TB are very compliant, a significant segment of the population with TB is, again, folks who are homeless, have a behavioral health, substance use issue, are folks who can't necessarily be counted on to take their medication as directed on their own. And so what the community paramedics are doing is augmenting the community health workers that have been employed by the TB clinic. They, call people who've missed an appointment. They find them when they're treated, when they can get somebody. And I think they've done a good job of working with folks to say, okay, let's get this treatment on a schedule that works for you and works with your TB doctor. One of the things I think that's been helpful is that the CPs have more medical training than the community health workers. The county is using, so they're a little more sophisticated. They've also gotten better cooperation from some of the challenging patients. Now, who knows why that is, but it is fair to say that the community health workers are primarily younger women dressed in street clothes. Our paramedics are gender-wise skew a little more male, and they wear a uniform. And I think it would be fair to say that with some of your more challenging patients, that may make a difference in how they relate and their willingness to cooperate. And I'm hoping our paramedics will share some of the stories you've shared with me about how you've worked with these folks. One of the other things that Ventura is doing is contact investigations, helping the county out with that. And you've helped with 6 to date, 1 in June 2016. And again, for those of you that don't know TB, contact investigations are where once you've identified somebody with active TB, you go out and you screen the family, you screen the coworkers. I think you had one of these, in a food processing plant where you had to screen, I think the county had to at least screen hundreds of people because of the potential for exposure. So again, really outside of the EMS box, but very important for public health. We're going to shift gears now. These 3 projects have really been examples of where the paramedics have done something that goes beyond traditional EMS work. The next 3 that we're going to talk about are alternatives. They're all cases in which the CP response is triggered by a 911 call, but there's an alternative to the reflexive just transport them to the emergency department. So hospice. I think this is the group where one of the initial reactions, I think, Dr. Backer, if you remember, was, well, why is this necessary? Hospice patients don't call 911. They know they're supposed to call the hospice agency. Now, I think we're hearing some giggling in the room because those of you who respond to 911 calls know that that's not always so. Sometimes folks don't really understand they're supposed to call the hospice agency. Sometimes they don't want to call the hospice agency. And unfortunately, sometimes they call the hospice agency and nobody answers, and they understandably get frustrated, and they call 911 because they know that they can count on their first responders to show up. And so this project also in Ventura is a partnership between American Medical Response, the 911 emergency response provider, and local hospice agencies. And here for the partnering hospices, there is the names of the folks who are on hospice care are provided to dispatch. So when a 911 call comes in, there's a flag that says, this is a hospice patient. Need to get the community paramedics involved. And so you'll have a regular 911 response, but you also send the community paramedic to really take the lead, assess the situation, get on the phone with the hospice, and try to figure out what's best for the patient. And you care about and in some cases, hospice is already on scene. And so why do we care about this? Well, it's 2 reasons. I mean, the first and foremost is for folks who really do truly want to be on hospice and really truly do want to be at home. Everyone, I think, want the hospice, EMS, all of us want those folks to be able to stay at home. The second is, if they don't stay at home, there's a risk that the hospice benefit is going to be revoked. And they'll be there in the hospital. They'll have to go back and reapply for hospice. That's challenging for them. From the financial point of view of the hospice, that's also challenging. So there's, patient interests and some financial interests here. This is just a snapshot from second quarter 2016. 16, 24 folks enrolled, 7 transports, or a 29% transport rate. And across the whole period from when the hospice project started in August 2015 to June 2016, the transport rate was 31%. And that's down from almost 100% prior to the pilot. So that's a pretty impressive reduction. Now, it's not zero. Well, why is that? Well, sometimes folks have injuries that are unrelated to their hospice, the reason they're on hospice. So they say they're on hospice because they've got congestive heart failure or cancer, but they fall and they break a limb, or at the very least you want an x-ray to rule out a broken limb. Well, those are ones where you can't just provide the care at home. You do need to transport in order to meet that need. Other times there are family members or who really insist on transport to the ED. So I don't think you're ever going to get this to zero, but dropping it to a third, what this is really doing is sitting down, and the CPs are coordinating with the hospice providers and really saying down, okay, what is it that this person needs? What can we do? If it's pain relief, how can we make them more comfortable? If it's that the family is really not sure what normal breathing at the end of life is like, and needs to be reassured that, yes, this sounds scary, but it is the normal dying process. And so a lot of it, I think here, you all will talk about it more, is an aspect of providing that social, some pain relief, but a lot of social, emotional support to folks who are going through very difficult challenges. So alternate destination, behavioral health, again, we'll hear more about this later. This is the project in Stanislaus County, and you've also got the case study here. And so this is saying for those folks for whom there's a 911 response where the need is truly a behavioral health, mental health need, let's offer an alternative to going to the ED. And the reason this matters is these folks, the norm is you take them to the emergency department for a medical clearance, for emergency department staff to look at them and say, okay, is there do they have a medical need that we need to take care of here? And then if the answer is no, then they're transported to behavioral health. The idea behind the Stanislaus Project is let's train up our paramedics to do the medical assessment in the field. And if we can in the field say, okay, this is someone who doesn't have a compelling medical need to be in the ED. This is somebody who has a mental health condition of a severity that can be managed in our county behavioral health system, who doesn't have co-occurring active substance use disorder. For those folks, let's offer this alternative of going straight to county behavioral health. And this some of these are folks who are on a 5150 hold, which those of you who are in mental health know that's the involuntary hold. Some are not. But the idea is for these folks offer an alternative that gets them to behavioral health faster. And so I've really got to do a Stanislaus has just been one of our I call Lance Doyle, their data person, my rock star data analyst. I'm serious because Lance is always on top of it, and that's reflected in these data. So they started up in September 2015 through June 2016. They have screened 550 people, and so these are 911 calls that come in with a behavioral health need. Some of them, the CPs are dispatched with the 911 crew directly. Other times, the regular 911 crew is dispatched, and it's clear that there's a behavioral health issue and value to getting the CPs involved. Some of these are ones where law enforcement responds to the call initially, and law enforcement says, hey, I think I've got a behavioral health need more so than a criminal need. Can you guys assess and help us take care of this patient? And as Dr. Mackey will say, I think that this has been the police have found this very helpful. So of the 550 screened, 27% were deemed medically eligible and enrolled. So in other words, they were screened and found not to have a medical reason to go to the ED. 30% were eligible but not enrolled, and that largely having to do with two things. One, the county's capacity in its behavioral health facility. And second, because of that capacity constraint, the county's decision that they were only going to offer this to folks who are on Medi-Cal, who are uninsured. So let's think about this some more. We've got an alternative for Medi-Cal and uninsured that's not offered to Medicare and private insurance. That's pretty unusual. Usually works the other way around. But anyway, 43% that did not pass the mental health and well person algorithms. So again, this doesn't mean that you're taking everybody out of the ED. It means that you're in the field screening and saying, of these folks, who really needs to be in the ED and who could go straight to behavioral health. In second quarter of 2016, nobody was transferred to the ED from the behavioral health center. I mean, this was a safety concern that I think all of us had, was how good of a job will the community paramedics do on triage of folks, and are we going to see rapid, folks going over to behavioral health who really should be in the ED? Well, in this last quarter, nobody's been transferred. In previous quarters, there were some transfers, but it's to say for fairly minor reasons. Incontinence, someone needed a CPAP machine and the county inpatient behavioral health isn't set up for that, so they needed to go to the ED and then get transferred to a private facility. Some level of agitation the behavioral health facility could not manage. So, I mean, no one, none of the ideal, as I think Stanislaus got to, is to avoid transfers altogether, but the ones that have happened have been fairly minor, and I think, as Dr. Mackey may tell you, there's been a real concerted effort between Dr. Mackey and the clinical leadership of county behavioral health to refine the protocols, come to consensus, so that really and truly the only folks that are going to county behavioral health are folks that county behavioral health is ready to accept and treat. Okay, alternate destination medical care. And so these are the projects that for folks with minor injuries, minor illnesses, are offered the opportunity to go to an urgent care center instead of an emergency department. These are probably the projects, these are the projects we know the least about. The enrollment numbers in these have been small, as you'll see on this slide. Only 18 enrolled in second quarter of 2016, pretty low enrollment overall. So we just don't know a lot. We've also had some issues here with two types of transfers. Continuous transfers are those where the 911 crew has offered transport to the urgent care. The patient has said yes. They get to the urgent care center, and the urgent care center says, no, we can't take them. Now, some of these are things you couldn't have predicted. One case in UCLA was that the x-ray machine was broken at the urgent care center. Now, probably you'd have transported the next day, it would have been fine. 3 were transfers within 6 hours. I think, as Dr. Backer alluded to, I think we're learning a lot here. We've had to learn a lot on the fly, and the projects will maybe talk about this, about what urgent cares can and can't offer. One thing that is a big difference is that a lot of the urgent care centers generally don't offer opioid pain medication, something that's pretty standard in an ED. Numbers of barriers to enrollment here, just flag a few of them. UCCs are open limited hours, some of them not much more than 9 to 5. Maybe open on the weekend, but they're not 24/7. And so anybody who's worked in 911 response knows you're going to get calls at all times of the day. I've mentioned the limited services. One of our projects, Carlsbad, has been limited to one payer, Kaiser, and to non-elderly Kaiser, and I think that's made it really hard for them to enroll folks. One jurisdiction, Orange, didn't initially train all the paramedics on the protocol for screening for offering urgent care, and they're still in the process of getting that up and running. So, I think the message on this one is we just don't know. We don't have enough enrollment. I think what we can say, though, perhaps on the safety front, is that we've not seen things that are really jeopardizing putting people's lives at risk or putting them at the risks for serious injury. That a lot of this has been more about what services are offered. So, I don't think we have a safety concern, but again, we just don't know a lot about how well it works because we don't have the enrollment. So briefly, conclusions and next steps so we can stay on track. Again, I think what we've seen about the transfers to urgent care centers and behavioral health facilities, it suggests to me that it's safe. Now, disclaimer here, I'm not a clinician, but these cases have 100% case review locally, review at the state level. I mean, I think these have all been have been very well vetted by folks who know a lot more about clinical care than me, and all have come to the same conclusion about safety. In terms of outcomes, we're seeing decreases in 30-day readmission rates, at least from our statewide benchmarks. We know that the transports of hospice patients and behavioral health patients to EDs are down considerably. We're seeing decreases in ED visits among the frequent 911 callers. We're seeing increases as well. I think we're seeing a lot of increases in patient knowledge of how to manage chronic illness. Now that's, not as easy to measure, but I think from the impressions that we've gotten as we've done site visits and interviewed the community paramedics, that clearly seems clear that some folks have gone from understanding almost nothing about their illness and thinking they're the only person in the world who has it to becoming fairly good at managing it. Definitely more access to medical and social services, the things that will help folks stay out of the ED and out of the hospital. Certainly there's been an increase in Ventura in the number of TPE patients receiving DOT, directly observed therapy, and that while we don't have that's certainly has the likelihood of reducing transmission in Ventura and improving public health. That because TB not only contagious, but it's also an illness where taking your medication as directed matters tremendously to avoid not only to avoid spreading it, but to avoid drug-resistant strains that are that much harder to treat. So what are our next steps in the evaluation? We will be doing a report to the public on findings in early 2017. That report will provide findings from June 2015 through the end of September 2016. We're going to describe the patients and the served and the services, the outcomes, and do estimates of costs and savings for the pilot projects. And so Cynthia Whitus, who has been with me on this project from the beginning, is now here. She had a little bit of delay with her flight. And Cynthia is really the person who holds together our implementation, evaluation, our quantitative data, and we couldn't do this without her. Want to also thank all of our other folks. And Lou, should I take questions, or do we want to just move on to the next? Okay.
The patients that were enrolled in any of the concepts, were any of them enrolled in numerous concepts? For instance, I immediately come to mind that some of our frequent 911 users also could benefit from the post-discharge and also behavioral health. So were they only one concept per patient, or were some enrolled in multiple concepts?
So the question is, were patients enrolled in multiple concepts or only one? And I would say pretty much only one. And I say that because most sites were only testing one concept. So if you're only testing post-discharge, you're really not set up to offer frequent 911. I'm looking at Rick Zombeck from Alameda. Did you have anybody that you enrolled in both? At Rick's project.
Occasionally that happens, but I'm sorry, Lou. I was just conferring with Elsie next to me here. She's our data collector, and we have had a few, but typically not, but on occasion, and because we are doing 911 and post-discharge.
Right. And then, Ventura is doing two projects, tuberculosis and hospice, but those are two totally different populations. It just would be odd for you to have that crossover. But great question.
Other questions?
So up here in the jacket.
Thank you. Do you have any inferences about the relatively high enrollment in the post-acute? It seemed like of all the different programs, the post-acute had the highest enrollment.
Okay, so my first inference is that's tested in 5 sites. The others, frequent 911 is only 2 sites, hospice is 1, TB is 1, alternate gestation behavioral is 1. So some of it's just you got more, if you're offering it in 5 places versus 1 or 2, that's a lot of what's going on. And those 5 places are Butte, Solano, Glendale, UCLA, San Bernardino, and Alameda. See, I told you it's hard to keep track of all of it. And so that's it. And then Butte in particular, I think you just have had really high demand there in Butte. And partly you're partnering with Inlow Hospital, which is the major hospital there in that part of the North State.
Okay, any other questions? All right, Dr. Coffman, thank you.